afternoon, everyone. Thanks for joining us on Facebook Live. My name is Dr. Johnathan Bernard. I'm with OrthoVirginia, sports medicine specialist, orthopedic surgeon. I specialize in shoulder, knee, and arthroscopic surgery. Again, excited to be here. Thanks for having me. I'm going to be going over some updates on sports medicine and specifically the treatment of cartilage injuries, some differences between cartilage injuries and arthritis, some of the latest techniques that we use for cartilage restoration, repair, and reconstruction, and then available to answer any questions that you have. So again, my name is Dr. Johnathan Bernard. I'm here to talk about these cartilage injuries and to go over some treatment options with you guys. I get a lot of questions from patients just asking what cartilage is. So I'll spend some time just talking about what we do. So in sports medicine, it's not just athletes. I think it's really the care of anyone that's active because what we try to do to the best of our ability is to keep you moving. And so whether it's sports, whether it's recreation, whether it's simply walking and moving, that's our goal. And we have every tool available to keep you moving. The best analogy that I give to patients about cartilage, what it looks like during surgery or what it looks like inside your knee or your joint, is that cartilage is more or less the lubricant that allows you to move. Each joint has cartilage. Cartilage almost has the consistency of a coconut. It's precious, it's soft, it's irreplaceable. And when you have a cartilage injury, or when you say, oh, my cartilage is bone on bone, you've basically lost that white part of the inner part of that coconut, and it goes all the way down to the shell. And so once you start to lose that cartilage, you can't really replace it. There's certain things that we can do to try to restore cartilage or prevent that loss of cartilage. But, the best analogy that I give outside of the coconut analogy is that it's sort of like the surface of a road. It allows you to move that surface needs to be smooth. And sometimes when you start to lose the original surface of that road, we have to come up with different techniques to fix cartilage injuries. So what is a cartilage injury? Basically, it's an injury to the surface of that road. In this picture, you can see there's a pothole in the center of the road. The road around it is pristine, but that pothole is going to cause symptoms if you drive over it. And so depending on where the cartilage injury is, you may or may not have symptoms. You might be able to simply drive your car around or avoid that pothole. There are instances where you can't avoid it, and then you notice when you drive over it, and then you're symptomatic. You can get these cartilage injuries from a specific event. Sometimes it's overuse, sometimes it's an injury associated with ligaments. So one of the most common ways in sports medicine that we see these cartilage injuries is after an ACL tear. You have an injury to the ligament, the knee is unstable, you injure either the hard cartilage or the soft cartilage, which we call the meniscus, and then you become symptomatic from that cartilage injury. In kids, we sometimes see cartilage injuries from overuse. They have growth plates that are open, but you can get these cartilage injuries. The term we use is osteochondritis dissecans, where you can have this cartilage injury and it's from overuse, and simply it will heal with activity modification, no surgery required. Sometimes you have cartilage injuries that are associated with alignment. Certain conditions where you have extra pressure on the bone or extra pressure on the cartilage can lead to cartilage injuries. And in adults, we still give it the same initials, OCD, like osteochondritis dissecans, but we actually call it an osteochondral defect. And that's very different because some of these OCDs in adults we treat with surgery, but we also treat with correcting the bone and the bone alignment. And so it's more than simply saying, oh, I didn't really have an injury, but I have pain. It's like, well, some of these injuries are repetitive stress or long existing. So long as the remaining cartilage is intact, we isolate these injuries and specifically call them cartilage injuries. Another common question that I get is, well, is this arthritis? And some patients will say, well, I have a history of arthritis. My mom has arthritis. My dad has arthritis. Well, this must be arthritis. And to a certain extent, yes, it is arthritis, because arthritis is simply inflammation of cartilage. But you can see in this picture, it's very different from the isolated cartilage injury. Oftentimes, arthritis is a medical diagnosis. And so when we think about arthritis, we also think, okay, what are other things that could cause this? Certainly, you can have an instance where you have what's called post-traumatic arthritis. You had a previous injury, and then decades later, the knee, either having had a ligament injury, continues to have instability, or in other instances, there's extra pressure on that bone and not one area is injured, but lots of areas of the cartilage is injured. But many times when we think about arthritis, we think it's specifically inflammation of cartilage. And when we think about what causes inflammation, there are a lot of things that can cause inflammation. Most commonly, we think of what's called an inflammatory arthropathy. So an inflammatory arthropathy is when your body creates inflammation that targets ligament, tendons, cartilage, or bone. And most commonly, we think of things like rheumatoid arthritis or psoriatic arthritis. But there are other types of arthropathies that lay crystal inside joints. Those include gout or pseudo-gout. Sometimes you can have an infection after surgery, or an infection that is in your blood that goes to your joint. One common one is Lyme. Lyme can cause arthritis inside the knee. And then things like obesity, that causes mechanical load, but we know obesity also increases your level of inflammation, and conditions like diabetes that also subtly raise the level of inflammation in your blood that can lead to degradation or inflammation of cartilage. And ultimately, like this picture, you can see that it's not just one area, but there's lots of areas of inflammation, lots of potholes, lots of loss of that surface of that road. And you can imagine driving on a road like this, you can't simply avoid one pothole. You may drive over multiple potholes at any given day. It doesn't matter the speed or how you drive the car, they're almost unavoidable. And so when we think about this, when we think about an isolated pothole versus or irregular surface, our treatment options, you can imagine, are going to vary significantly. When we think about potholes and we think about arthritis, we're limited with our options. Many times we think about conservative treatment. You know, typically, if you're able to drive on the road as long as you can. If you're able to tolerate the surfaces as long as you can. In arthritis, medically treating it might be what are called disease-modifying agents. For rheumatoid arthritis. Certainly for gout, it includes gout medications. If you have an infection, you treat the infection. And certainly if there are cartilage injuries that are causing inflammation, our clinical practice guidelines through our academy are pretty clear about the role of anti-inflammatories, weight loss, physical therapy, exercises. Those types of things are very basic treatments for the treatment of arthritis. Sometimes we use braces. Sometimes we try to strengthen the tendons. Tendons attach muscle to bone. So if there's inflammation of the tendons, we reduce that inflammation, work on strengthening activities. Of course, surgical solutions, as you can see on the schematic on the right, include simply replacing the potholes, and the joint replacement and arthroplasty are proven, been around for decades, and are an effective treatment for arthritis. Cartilage injuries, though, are a little more complicated. There are a lot of options. They depend on the size, they depend on the location, they depend on things like your alignment. And so we always get x-rays. Some patients say, you know, Dr. Bernard, I know it's not the bone, I need an MRI. And I say, absolutely, we'll get your MRI. I would also like to get x-rays, because the x-rays give us a good sense of your alignment. It gives us a good sense of how much of the cartilage injury involves the bone. It gives us a good sense of the presence of arthritis. And it gives us a good sense of ways that we can treat these cartilage injuries. We often consider either repairing a cartilage injury, preserving as much of your cartilage as we can. And for some conditions where the bone is loose and there's a chance that the bone will heal underneath it, very similar to how we treat fractures, we try to internally fix cartilage injuries as well by holding the bone stable. Sometimes we try to regenerate cartilage, and we use different techniques to provoke a healing response. And Dr. Richard Stedman, who recently passed away, a huge loss to the sports medicine community, he was really a pioneer with the technique called microfracture, which drilled drilled the undersurface of the bone below the cartilage that helped stimulate a healing response. And so we use those techniques, and there's different generations of those techniques that we use now and that we employ to help stimulate that repair response. And then sometimes we have to reconstruct the cartilage. You know, it might not be something that we can repair or regenerate, but we'll simply use some of your cartilage from another location or cadaver cartilage that has live cartilage cells and simply fill that defect so that you're able to put pressure on it and weight bear sooner. And so as we talk about our different options to treat these cartilage injuries, I'm filled with analogies. I like giving golf analogies for this because it gives you a good sense of the different ways that you would treat it, and just the way that soil and topography can influence how a landscaper would address different challenges in surfaces and turf. We take a similar approach for cartilage injuries. So the first picture, whether it's a shallow divot or a deep divot, that's sort of the analogy of a superficial cartilage injury or a deeper cartilage injury. Superficial injury that isn't that big, that doesn't involve a lot of bone, that you might be able to avoid. We might simply say, let's treat this without any surgery. Let's try some therapy, see how symptomatic you are. Because it is shallow, some of the techniques that we use might not include a lot of soil. It might simply include something like a microfracture or what's called biocartilage. There's some techniques that we use allograft or cadaver cartilage as well that stimulates new cartilage growth. And sometimes we do a procedure called MACI, where we take some of your cartilage, we grow it, populate it, and then put that cartilage in that area. And that would be something that's shallow but wide. Deeper cartilage injuries or a deeper divot would involve both the cartilage as well as soil, so cartilage and the bone. And for those injuries, we call it an osteochondral allograft or an Oates procedure, an osteochondral autologous graft. And that's where we take some of your cartilage from another area that you might not notice with activities, and we put little plugs in to recreate that defect. And there's lots of different ways that we can do that. Sometimes one plug, sometimes we put two plugs together. It kind of looks like a snowman. Sometimes we take a longer plug from cadaver tendon that has live cartilage in it, and we can fill different types of shapes based off of the contouring of the injury. Below, you can see where we're using seeds to regrow grass. Those would be procedures that, like the MACI procedure, where we take some of your cartilage and we grow it in a lab, and a couple of months later we reseed that surface area. Sometimes we do what's called de novo, which is another type of cartilage implant to kind of recreate that, and that doesn't involve bone. And then the very last schematic, you can see, well, we're going to resurface the entire area. You know, we're not repaving it, we're just adding new soil across a larger area, and that would be analogous to what's called an osteochondral allograft. And again, whenever we're doing these things, there are other things that we consider. Each of these surgical procedures carry their own restrictions, whether it's weight bearing or range of motion. It depends on the location that you're doing the surgery. For example, in the knee, there's lots of areas of cartilage. You have cartilage underneath your kneecap you have cartilage at the very end of your thigh bone or your femur. And so depending on where the area is, there's different things that we do to either protect the cartilage. Many of these surgeries, though, the ultimate goal is to get you back as quickly as possible. So many of the procedures allow you to start to bend your knee pretty quickly after surgery. Many of the procedures, so long as it makes sense, have you start to put a little bit of pressure across your knee. In the shoulder, we do some of these procedures sort of along the same lines. The shoulder's a non-weight bearing joint, but we have you start to do some early range of motion because that has been shown to be healthy for cartilage. It's good for your joint, it's good for your tendons. And then as things heal, we start to advance things, whether it's early strengthening, whether it's complex what's called neuromuscular control, all of those things that we're able to kind of assist with your physical therapist and with your home exercise program. Many of the reconstruction techniques that involve bone allow you to put a little pressure on the joint sooner than some of the superficial techniques. And so some of the Oates procedures where we use your bone and cartilage, or the osteochondral allografts where we use cadaver cartilage, allow you to start to put some pressure on that joint sooner than you otherwise would. So gone are the days of non-weight bearing for 3 to 6 months, which is what we used to do several decades ago. And some surgeons still do. A lot of those reconstruction techniques, I'll sometimes add what's called an unloader brace. So depending on where the cartilage injury is, there's special braces that we can have that you can start to put some weight on it even sooner. And then ultimately the question is, why did this happen? Are there ligament injuries that we need to also factor in? Are there alignment concerns that we have that also need to be addressed? And those are some of the things that we, especially with some of these cartilage injuries, there's often what we describe as concomitant injuries and concomitant surgeries. Sometimes we'll do the bone plug and the cartilage with a meniscus repair, and that's sort of the role of joint preservation. We're trying to do everything to stave off that arthritis, preserve the cartilage that you have, but also respect the other structures that may be contributing to the divot. Maybe contributing to the irregular surface. And so we address those, we address the alignment, we repair any ligaments or reconstruct them at the time, we fix the meniscus, we kind of optimize things so that you can get back to all the things that you want to be doing. All right. So I'll pause there with the PowerPoint, and we'll kind of open things up for any questions or any comments, any feedback from you guys.
Thank you so much, Dr. Bernard. And there is feedback coming in. There are some questions already asked. So one of the questions was, what can be done for thinning cartilage in the knee? Are there supplements that can help?
Yeah, great question. What we know about some areas of the knee that start to get early cartilage thinning, and the term we use is chondromalacia of the patella, or chondromalacia of the femur, or chondromalacia of the tibia. What we often know is that therapy and strengthening exercises can help unload the cartilage. Many times it's cartilage overload that leads to the thinning. Sometimes it's genetics. Sometimes it's multifactorial and more medical in nature. It's challenging to really regulate the different types of available supplements that exist. Studies often are inconclusive, but I'll tell patients anecdotally, so long as it doesn't interact with other medications, you can certainly try different types of supplements to assist with that. In most cases, though, there's nothing official that we would recommend in terms of supplements other than what would otherwise be recommended through, our societies for nutrition and multivitamins and so on.
Thank you. How young is too young for surgery to repair or reconstruct cartilage?
I'm sorry, say that one more time. How young is too young?
How young is too young for surgery to repair or reconstruct cartilage?
I think it depends on what we would call the pathology, and so oftentimes, depending on where the injury is and depending on the patient's age is how we dictate treatment. So for example, and I earlier spoke about what's called osteochondritis dissecans. What we know is that a cartilage injury associated with osteochondritis dissecans might appear in children as young as 6 or 7 if it's overuse. We do know when the growth plate is open for that condition, there's a high likelihood that the cartilage can heal itself with conservative treatment. There are instances where that fragment may become unstable or loose, and we know that the natural history in that scenario would lead to arthritis. And so there are indications to do a surgery regardless of age based off of the injury that we see. Having said that, I think it's pretty rare to do surgery on someone that young, but we do have teenagers that have osteochondritis dissecans or cartilage injuries that require surgery. ACL injuries are becoming more and more prevalent. We see a lot of ACLs younger and younger. I've taken care of patients as young as 12 with ACL injuries, and we're doing pediatric ACL reconstruction. Some of those patients may have cartilage injuries. Certainly if there's other injuries associated with the cartilage, like post-traumatic injuries, sometimes patella dislocations. I've taken care of patients as young as 13, 14, 15 with patella instability that we've done cartilage surgeries on. So I think ultimately it's less age and more a matter of the injury and what's called the natural history. In other words, is this an injury that will heal on its own? Is this an injury that will get worse with time? And the younger you are, the likelihood that these injuries are related to a cartilage injury and not necessarily arthritis. I think once injuries become arthritis, they're much more challenging to treat. And I have seen some patients in their 20s and 30s who now have arthritis or post-traumatic arthritis from injuries that weren't addressed. And in that setting, it is much more challenging to treat. And often we do not treat arthritis with the same types of cartilage repair techniques that I previously discussed.
Thank you. You've mentioned the knee a few times. Is this information the same for shoulder cartilage?
It is the same with some slight variation. So often arthritis in the shoulder appears at what's called the glenoid. The shoulder is like a golf ball and a golf tee, but vertical. And the humeral head, which is the golf ball, because of how it is shaped, it is increasingly difficult to treat isolated cartilage injuries that appear on the golf ball. There are some injuries that occur on the glenoid, and some of the techniques that we use to restore that glenoid cartilage are based off of the injury. So for example, I've taken care of some patients who have lots of shoulder dislocations. When you have a shoulder dislocation, you slowly lose the cartilage in the very front of the shoulder if you have an anterior dislocation. And I've done some cartilage procedures or what's called an osteochondral allograft to the very front of the shoulder to restore that missing cartilage. And so it does depend on the location. Some of the procedures for the shoulder were limited with how we can do it, but the techniques that I described are universal. So they apply to most major joints, whether it's the shoulder or the knee. They apply to the elbow as well, because you can get a lot of these conditions in the elbow, and you can also get them in the hip and the ankle.
Thank you. How do you tell if it's a cartilage injury or arthritis or something else like a rotator cuff tear?
Yeah. Great question. So much of what we're able to help determine like the nature of these injuries often starts with the history, so just talking with patients and trying to understand how their shoulder hurts, or how their knee hurts, what activities they do, what they're not able to do, some of the treatments that they've tried, really helps narrow down what path will determine our treatment pattern. X-rays are extremely valuable. Some conditions you can start to see changes on the X-ray even before we order an MRI, and that's very helpful to kind of narrow down what we're thinking in terms of what we call a differential. So a differential in my mind, I close my eyes, I think about every possible thing that they could be. And we slowly start to narrow things down based off of what patients tell me. And then the MRI really helps treat or helps determine how we treat it. MRIs look at ligament, tendon, cartilage, and bone. Ligament connects bone to bone. Tendon connects muscle to bone. So some conditions like instability, for example, whether it's in the knee, you often tear a ligament. And so we're looking for bone bruise patterns from that ligament injury. We're able to kind of discern, okay, is this a new injury or an old injury based off of how the bone looks. For tendon injuries, we're able to see on an MRI if the tendon's retracted. When a tendon tears, it's like a rubber band, the muscle pulls back on the tendon. And so some injuries that just occurred, there might not be a lot of movement of the tendon. Injuries that have happened for a while, you can see a lot of retraction of the tendon. And then, of course, when you have ligament or tendon injuries, they influence cartilage. And so some injuries, for example, rotator cuff tears, we know the natural history of a rotator cuff tear, you can get progressive arthritis. And so some patients that may have a rotator cuff tear that's been going on for a very long period of time might develop a lot of arthritis inside the shoulder. In that situation, we wouldn't necessarily recommend a shoulder repair of their rotator cuff. We would actually watch with physical therapy and ultimately recommend either a shoulder replacement, which would take care of both the rotator cuff problem as well as the arthritis.
Thank you. Can you explain again how treatments differ between damage from injury and damage from wear and tear?
Absolutely. So damage from wear and tear can happen for a number of reasons. Sometimes it's in addition to environmental impacts, whether it's activities or previous injuries or medical conditions. Sometimes it's genetics, just how well the cartilage holds up with time. And as that cartilage either is unable to support the structure of the joint, many ways that we treat that early cartilage wear and tear is through things like therapy or medication, sometimes injections. Cartilage injuries, though, often occur after a specific incident. You know, you're running a marathon and you noticed some increasing pain in the knee and now it's swollen. And most patients are able to kind of say when they were good and when they weren't. They kind of have a sense of when that occurred. Most commonly, it's after a specific injury. And most commonly, at least in sports medicine, it might be after either an associated ligament injury or a fall or a twisting mechanism. And so many times we have good insight into the mechanism of injury, and that helps narrow in on identifying some of these cartilage injuries in the moment, so to speak. MRIs also are helpful to understand where the cartilage injuries are, as well as helping to understand where else the injuries may be involved. And so using the road analogy, it's one pothole versus many potholes. Many times if there's lots of cartilage injuries, even if it isn't medical arthritis, it might be a post-traumatic arthritis, and that would influence how we treat. For example, we wouldn't necessarily try to put so many cartilage plugs across so many arthritic areas. It wouldn't provide long-term relief for one's symptoms. And so sometimes we consider other treatment options that would provide greater relief just by doing one procedure or one surgery.
Thank you. Do stem cells or PRP help cartilage?
Yeah, so one thing I did not talk about, and that's a great question, are what are called biologics. Biologics vary, and there are a lot available. Things like PRP, so PRP stands for platelet-rich plasma. It's a procedure or process where your blood is spun by a centrifuge, and certain elements that help stimulate inflammation are separated from the rest of the blood products. PRP is amongst a number of different biologic techniques, and some include what's called mesenchymal stem cells or adipose-derived stem cells. There are a lot, and the idea with PRP or any biologic is to provide relief of symptoms. And so when I counsel patients on PRP, and we do PRP in the office, we sometimes do PRP at the time of surgery, we use it as a adjuvant to help with symptoms and help promote a healing response, especially at the time of surgery. There's some good evidence to suggest that PRP compared to cortisone provides longer relief with less side effects. And so increasingly, we're using that as an option to help with patients and to help with their symptoms. But unfortunately, PRP is not a cure for arthritis, and it's not a cure for cartilage injuries. It's an option to help with symptoms. And sometimes if you're less symptomatic as a result of the PRP, it allows you to either delay or defer or to avoid cartilage surgery or cartilage repair techniques. But sometimes, depending on the pattern, the size, the location, PRP often doesn't make sense if there's an injury that either needs to be repaired or reconstructed. But it's certainly an option, and I encourage all my patients to explore all options when considering any treatment.
Thank you so much, Dr. Bernard. That is all the time that we have for today. If we did not have a chance to answer your comments live, we will follow up in the comment section. Dr. Bernard, would you like to close?
Yes, thanks for having me on. It's a topic that I enjoy, and I enjoyed speaking with you guys and answering your questions. And then anything you need from us, feel free to come to our website, OrthoVirginia.com. And if you need anything, we're available.